Welcome and thank you for joining us for this international clinical debate on the future of cardiovascular risk assessment. We're delighted to be hosting this event on World Heart Day, and tonight we've got some 1,200 people from around the world, and a special welcome to those in the Northern Hemisphere. It's evening time here in Australia, morning for you. We'll soon be hearing from a very esteemed expert panel on the debate question: should population-based cardiovascular disease risk assessment models make way for individualized risk prediction techniques? But first, I'd like to begin by paying my respects to the traditional owners of the lands on which we meet and Indigenous people around the world. We'd also like to pay our respects to the elders past and present. I'd also like to acknowledge the World Heart Federation because it is World Heart Day and they're helping bring this event to you. They've partnered with the Heart Foundation of Australia to bring this event to you. We'd also like to thank our sponsors, Servia, who've supported this meeting with an independent educational grant. I'm Gary Jennings. I'm Chief Medical Advisor to the Heart Foundation of Australia. I'm a cardiologist, and as I said, we have a most distinguished panel of experts in cardiology who tonight will be bringing the latest evidence on this topic. We'll start with Professor Donald Lloyd-Jones from Northwestern University. He's one of the most highly regarded experts in cardiovascular disease prevention and epidemiology. He's chair of the Department of Preventive Medicine and the Arlene M. Fold Professor of Heart Research and Professor of Preventive Medicine at Northwestern University in Chicago. He's also President-elect of the American Heart Association. We have another well-renowned expert in this field, Professor Stephen Nichols. He's Director of Monash Heart and Director of the Victorian Heart Institute. And Gemma Figtree, who's a cardiologist at Royal North Shore in Sydney. She's also, amongst other things, President and Chair of the Australian Cardiovascular Alliance, and again, another very distinguished expert in this subject. So a little bit of housekeeping. If you've got questions, feel free to ask them. Just type it into a Q&A box at the bottom of your Zoom window. Over 100 questions have already been submitted to the panel. We'll do our best to address the most, either the most popular or the most pertinent questions. So cardiovascular disease, of course, is the leading cause of death worldwide, and we want to know who's going to get a cardiovascular disease and who's less likely to. And that's the beginning of the journey for our patients. Of course, we want to make sure that the right people get their treatments, that people that don't need treatments don't avoid it. And that's where cardiovascular risk prevention comes in. And we've had a lot of ways of doing this using population-based risk algorithms, which vary around the world with different populations and different applications. But of course, there's a multitude of new tests coming along, whether they're imaging, whether they're related to biomarkers, genetics, and part of our discussion today will be how can we fit these into clinical practice? Is it ready for prime time? Is it too early? Do we need to do anything more than what present guidelines suggested? So I'm going to start with our first speaker, as I said, Professor Donald Lloyd-Jones, and he's going to give you an introduction into particularly the population-based risk algorithms and where they fit, calculation of absolute risk. Thank you, Don.
Gary, thank you so much for asking me to join you this evening, and greetings to everyone. It's actually early morning here in Chicago, so that's why, actually, I guess you can't see behind me, but it's quite dark outside here. So, all right. Now, are you seeing my slides? Can I get a thumbs up? Excellent. Okay. So as Gary said, my task is to set the stage with the current paradigm of risk assessment for prevention. So I'm going to be talking about population-based cardiovascular disease risk assessment models. And I have no conflicts of interest. So obviously, we've known about the modifiable traditional cardiovascular risk factors for decades. In fact, the term risk factor was first coined in a paper from Framingham in 1961 by Bill Cannell. And of course, those modifiable risk factors were discovered because of their strong causal relationships with disease in populations, and obviously the clinical observation that they were also associated in individuals. Over time, though, I think there was a realization that just looking at those risk factors in isolation was not as helpful, and that the global burden of risk factors was more useful in understanding a person's risk for disease than just looking at single risk factor levels. And so accordingly, in the early 90s, risk equations for predicting cardiovascular risk were born. And those, of course, were based on population level estimates. You need groups of people observed over time to be able to create predictive equations. And I would say this is just exactly akin to the way we practice all of our medicine. All of our approved medications, for example, have gone through clinical trials on populations of individuals, and we use those medications expecting an average effect, for example, for statins or blood pressure lowering, just the way these equations are derived from groups of people, and we apply them to individuals, expecting that on average they will be close to what we will observe. Subsequently, though, and there are some real limitations to this approach, there has been an unending search for additional biomarkers of risk or biomarkers of disease to help refine these risk assessment approaches and help improve decision-making for prevention. So just as an example, this is what the Framingham coronary heart disease risk equations provide you in terms of risk assessment. And notice you can plug in different values into these risk equations. What I've done here is taken average risk factor levels for a 60-year-old man, so a total cholesterol of 200 and HDL of 50, non-diabetic, non-smoking, and then changed his risk factor levels, made his cholesterol higher, dropped his HDL, made him a diabetic, made him a smoker, and notice there's a pretty substantial increase in his risk, including within each risk level, his blood pressure. And notice that the additive burden of risk increases more steeply as you add in more and more of these risk factors. So it's very important to consider the global context of all of the risk factors and not just focus on a single one of them. So that sort of begs the question, why do we really focus in now on short-term absolute risk prediction as our means of making decisions? Well, relative risk is really poorly understood by both clinicians and patients because it's always hard to understand who am I referring myself to? Who am I comparing myself to when I hear a relative risk of 3 or 5? If I'm comparing myself to a very low risk person, a relative risk of 3 or 5 is still very low. So it's important to understand absolute risks for prognosis to give a reasonable estimate of what this patient's future looks like. It helps us improve our communication and can motivate lifestyle changes and adherence to our recommendations. As you all know, the current paradigm is that we want to match the intensity of our prevention efforts to the absolute risk of the patient. So everyone should get lifestyle recommendations as needed, but only people at sufficient risk are recommended for drug therapy because we want to identify those individuals who are at high enough risk to merit drug treatment and where we can expect sort of net cost-effective benefit, where the benefits of taking the medication outweigh any potential harms. And so on this absolute risk scale, we can directly compare the benefits and potential harms of therapy with things like numbers needed to treat and numbers needed to harm. But there are limitations, as I mentioned, and so looking only on short-term risk estimates doesn't give the complete picture. This is a life course disease. We know that any single risk factor, if left untreated for a long time, can certainly produce disease. But because age is such an important driver of risk, which is true, people complain about that, but of course it's the most important driver of risk because it integrates our cumulative risk factor burden. Almost all men under 50 and almost all women under 70 are going to be considered to be at lower risk. So that's sort of frustrating, which is why long-term and lifetime risk estimates have come into being to give the fuller picture to our patients. And finally, the appropriate concern about applying those group estimates of risk to an individual are very valid. Risk scores get it wrong for individuals too often, and these are probabilities of an event, not certainties. Patients want to know, is it going to rain or isn't it? Should I use my umbrella today or not? Not, well, I have a 14% chance of having a heart attack or stroke. So it is a little bit unsatisfying. And that's why I think these approaches have evolved with sequential refinement of our risk estimates in order to make them more personalized to an individual patient. Which brings us to the current AHA and ACC US guidelines for cholesterol and overall primary prevention. If you're interested in taking a deeper dive, these are the headers of those documents. And I'll point your attention to a special statement that we put out on risk assessment, specifically to help clinicians understand how to do this approach. So this is the way risk assessment plays out in the current guidelines. We start by estimating the absolute 10-year risk as well as the lifetime risk for communication tools. But for medical decision making, we put patients in different buckets based on their predicted 10-year risk as a starting point. Then we refine that risk to try to individualize it to the patient sitting in front of us. And if we're still uncertain or we need a tiebreaker, then we use good imaging like coronary calcium scoring in order to really reclassify an individual if we're uncertain. So the way we do this in shorthand is we calculate, we personalize, and we reclassify when needed in order to help with our decision making. So to calculate, we use the pooled cohort equations, or the PCEs, which were derived from broadly representative population-based studies in the United States, and focused on a new endpoint of hard atherosclerotic cardiovascular disease, which includes both coronary disease and stroke. And that was really important because by including stroke, it allowed us to capture some of the risk that was left behind, particularly for women and for African Americans. So this new endpoint was very important for us. It's been widely validated. We understand how it works, not that it's perfect, but we understand how it works in contemporary US populations. And they're well calibrated near our decision threshold of 7.5% that comes from clinical trials. So as with all risk scores, they can underestimate and overestimate, as we'll look at in some subgroups. And we understand how they work, again, with coronary calcium because of some nice publications. So the way we use them is as I'll now show you. What we've discovered from a careful systematic review of how these equations work in the population is that across the broad US representative clinical population, they have good calibration, meaning if we predict a risk for a group of 7% over 10 years, it tends to be pretty close to that. But where they don't perform as well is clear. In patients who have higher socioeconomic status, who are going to be healthier than average and closely engaged with the medical community, they will always tend to overestimate risk. And at the other end of the spectrum, patients with lower socioeconomic status or who have chronic inflammatory diseases or HIV, they tend to systematically underestimate the risk. So it's important for a clinician to understand that and to impart that to the patient to try to individualize what the risk estimate means for them personally. So that takes us to the second part of the personalization process, is the clinician-patient discussion to consider risk-enhancing factors and the net benefit of therapy for this patient. So we identified a number of risk-enhancing factors that would refine the risk for an individual patient, and in each case, push that risk upward above what the predicted risk was from the equations, because we have good, safe therapies like statins, where we wouldn't mind treating more patients in order to prevent more events. So you can see some of the common conditions that we considered as up classifiers of risk for patients in order to personalize their estimate. And finally, if there's uncertainty or patient indecision remains, then considering a coronary calcium score, the best indicator of the actual disease we're interested in, that can be used in a broad scale as a decision tool, we reached for this one as the best sort of tiebreaker or decision tool to push us off the fence if we remain in the middle and without a decision. And the reason we chose that one is it does reclassify patients quite appropriately within the intermediate risk range, so that patients with a coronary calcium of 0 are all reclassified to lower risk levels, lower observed event rates below the statin benefit threshold. And patients with coronary calcium scores of 100 or above are all reclassified to at or above the statin benefit threshold. So it really does help you discriminate more appropriately. So calculate, personalize, reclassify, as we like to say, do this CPR now so you don't have to do that CPR later, and it will lead you to better decision-making for your individual patients. So to summarize, 10-year and lifetime risk estimates can assist with decision-making regarding the intensity of our prevention efforts, but those estimates start the discussion. They don't prescribe the drug. this is where the clinician comes in and works with the patient. So when applying those risk scores to individual patients, we have to consider personalized risk enhancing factors and apply them and up or down classify the patient accordingly. And then if clinical uncertainty or patient indecision remain, coronary calcium scoring is really our best tool to help improve decision making. And that's going to be more cost efficient than universal screening with better yield because it enriches the population. We first assess the risk with the prediction equations, and then we enrich the population to find those people who do or don't have CAC to make better decisions. So I think I will stop there just given the time, and I will look forward to our discussion with my colleagues. Thanks very much for your attention.
Well, you've set the scene beautifully. Thank you very much, Don. And quite a number of the questions that the audience submitted related to the point you just made about the role of cardiac imaging, particularly coronary artery calcium and CT coronary angiograms. And Steve Nichols is going to tell us a little bit about that. And he's also going to introduce the concept of polygenic risk scores, using genetics to see if we can move from group population predictions to predictions in the individual. Thank you, Stephen.
So you're on mute, Steve.
I just realised, sorry, apologies. Sorry, thanks. Can everybody see my slides?
Yes, we can.
Sorry, apologies for that. Thank you for the invitation to speak tonight. And what I really want to do is kind of take the baton from Don and really start to kind of put both imaging and genetics in some context of where they may play a role in risk prediction and guiding more intensive therapy, and kind of to suggest where we kind of sit at the moment from an evidence perspective. This slide summarises my disclosures. So as we've heard, there's a whole array of ways of calculating risk, and you know, while Don has shown you the US approach to that, there are a range of risk calculators around the world. We use them daily in our clinical practice, and it helps guide our use both of statin therapy and more intensive kind of risk modification therapies. But in parallel, we've also seen significant technological advances in arterial wall imaging over the course of a generation. We've moved well beyond simply being able to do a coronary angiogram. We can use invasive and non-invasive imaging techniques. We can image a range of vascular territories. We can not just see where the disease is, we can quantify the disease. We can start to distinguish its individual components. And with the advent of radioisotope imaging, we're now at the advent that we'll be able to start to measure, at least from a research perspective, the functional properties of the plaque within the artery wall. And what I think we've really come to in 2020 is really the important role of non-invasive coronary imaging with CT has very much become the go-to imaging modality if we're going to talk about kind of risk prediction. While I think there'd been a lot of work with carotid ultrasound and carotid IMT in the 1990s, I think the imaging resolution has improved substantially with CT imaging. The availability has become much greater, and I think the reliability of the measurement has become much cleaner. And so I think when we look forward in terms of what risk prediction looks like with non-invasive imaging, it's really a CT guided approach as opposed to an ultrasound approach. As you've heard, with a large body of work has not only shown that increasing coronary calcium scores associated with increasing risk, but importantly, it reclassifies risk. In addition, we've seen very similar data with both detection of plaque, mixed plaque, and significant kind of luminal stenoses on formal CT coronary angiography. I think that's a step beyond a simple coronary calcium test. It's more expensive. It's something that we largely reserve for a patient with a symptomatic indication, particularly still in that kind of low or intermediate risk kind of setting. But does it change what we do in the clinic? And that is where perhaps there still can be some work to help define how optimally imaging can guide medical therapy. Here is observational data from the MESA study, which you've already seen from a calcium score kind of perspective. It simply asks the question, if you have a high calcium score, did it change management? If you're already on risk modifying therapies coming into MESA and you had a high calcium score, your doctor was more likely to keep you on those therapies. If you had a high calcium score and you weren't on those agents, then you were more likely to be initiated therapy. So it definitely appears to influence both physician and kind of patient behavior. What if we simply show patients the imaging? Here is data from the Netherlands. More than 3,500 individuals between the ages of 40 and 60 with at least one risk factor underwent carotid ultrasound imaging and were randomized to be shown the images with a phone call from a nurse to talk about risk factor modification versus no information at all. And over the course of 12 months, you see that those individuals who were shown the lesions in the artery wall, they were given advice on risk factor modification, had much more significant improvement in their risk factor profile compared to the individuals who weren't shown their images. So showing the images can actually be a potent kind of motivator for patients in terms of compliance with preventive approaches and reduction in cardiovascular risk. What if we look at the use of CT coronary angiography? Can it guide therapy and can it have an improvement in clinical outcomes? Here is really quite compelling data from the Scott Hart study where individuals came in with atypical chest pain, low or intermediate risk. They were randomized to either standard risk prediction algorithm using a validated Scottish risk prediction kind of calculator, or to undergo CT coronary angiography with the results of the CT coronary angiogram guiding medical therapy. And as you can see, the patients who were randomized to the CT coronary angiogram arm, who ultimately did have a greater use of statin therapy, over time you can see that results in a significant reduction in cardiovascular events over the next 5 years. And so I think it reflects the start of what we're seeing of clinical trials looking at implementation and extending the results of observational studies suggesting that imaging of the artery wall is important to start to show that actually imaging can make a difference in terms of improvement in cardiovascular outcomes. In Australia, we are conducting a study using coronary calcium. This is an NHMRC funded study that's being led by Tom Marwick at the Baker that we're working with. We can get individuals with a family history of coronary disease who don't qualify for statin, undergoing calcium score. Those individuals with an elevated calcium score get a statin versus no statin, and looks at changes in coronary plaque volume on serial CT coronary angiography over time. It's not the large definitive outcome trial that would probably require 20 to 30,000 patients, but at least it starts to continue to advance the story about implementation and asking the question, can we not only reclassify risk, but can guide and change therapy and ultimately change outcomes for patients? What about genetics? So the story of genetics in atherosclerotic cardiovascular disease continues to evolve, and it really started with, really, as Don pointed out, early observations from seminal studies such as Framingham that identified a family history of premature cardiovascular disease events as a major risk factor. We subsequently learned about the importance of monogenetic disorders such as familial hypercholesterolemia as a driver of premature atherosclerotic cardiovascular disease. And for a long time, we looked for the single heart attack gene. While we thought from time to time we found something, all those kind of searches proved to be pretty disappointing. But what we subsequently saw with the advent and the technological breakthroughs in genomic sequencing was a whole host of genome-wide association studies that week after week after week continued to report a large number of single nuclear polymorphisms that associated with cardiovascular risk. And in fact, in this review paper in 2017, which tried to summarize at least what we knew to date, you can see a summary of a range of the polymorphisms that had been associated with atherosclerotic disease. And while a number of those polymorphisms pointed to particular mechanisms that we understood in terms of drivers of the disease, if you look at the right-hand side of the slide, there are a whole host of polymorphisms that associated with risk. We had no idea what the connection was between the genetics and the outcome. It's important in terms of continuing to drive the science because it has the potential to kind of inform new targets. But we can't really kind of continue to try and embark on trying to pick a needle out of a haystack in terms of looking for individual polymorphisms. And this concept of polygenic risk score calculation has really emerged in the last 5 years in particular. The idea that we can do these genome-wide association studies, we can find a whole range of polymorphisms that are associated with cardiovascular risk with different weightings, and we can use those to calculate a polygenic score. It's been used in the cancer space, in the obesity space, in the diabetes space, and now it's been applied to the cardiovascular space, and we can apply this to large cohorts and then kind of validate it kind of in subsequent cohorts. And what we've learned now is that we can calculate polygenic risk scores, where the individuals with the highest polygenic risk scores appear to have a much higher rate of myocardial infarction. Not only does it point to risk, but from an observational perspective suggests that there may be some modifiability of that risk. Here is kind of looking at a number of cohorts, looking at greater polygenic risk scores. The higher the polygenic risk score, the higher the 10-year rate of coronary events. But importantly, within each of those strata, individuals who adopted a more favourable lifestyle had a lower 10-year cardiovascular event rate, suggesting that your genetics did not seal your fate. It did point to some modifiability of risk, even in those individuals who had a high polygenic risk score. More recently, we've seen exactly the same observations when we've looked post hoc in studies of lipid-lowering interventions on the left, looking at studies of statin therapy. We've seen that those individuals with a high polygenic risk score at baseline, not surprisingly, had a higher event rate during those trials, but the absolute risk reduction we observed with statin therapy was greatest in those groups, again, reinforcing the modifiability of the disease. On the right, you see two observations of the large PCSK9 inhibitor outcome trials that have been performed in the last 3 years. And again, highest polygenic risk score, not only associated with a higher event rate, but we saw modifiability of that risk with intensive lipid lowering with the PCSK9 inhibitor. And so that has led us and others to start to think, well, how do we now try to apply polygenic risk score calculations from an implementation perspective? How do we move it away from the observations and move it into the kind of clinical trial situation? We have an MRFF-funded study. Gemma Figtree and I are leading this with colleagues. We're taking these individuals over the age of 18 with an LDL cholesterol greater than 1.8 millimoles per litre who don't currently meet the criteria for statin therapy and are undergoing a clinical indicated CT coronary angiogram. Those individuals with some degree of atherosclerotic plaque at baseline will be stratified according to low, middle or high levels of polygenic risk score. And within each of those levels, we are going to randomise patients to statin or placebo and look at the effect on disease progression. And what we're really trying to ask there in a prospective fashion, can we demonstrate that statin therapy favourably modulates disease equally, if not to a greater degree, in those individuals with a high polygenic risk score? It will be a step further towards how we work out how to implement these approaches into the clinic. And so I'll finish with, when we talk about risk, it's not just about defining risk, reclassifying risk. It's ultimately about identifying the individual who has modifiable risk. And that's really what we're trying to do here. We're trying to find the individual who's not only at a higher rate of having an event, but if we do something about it, it will actually reduce their risk. And I think that we're now getting to a point from an observational perspective where imaging and genetics may help, but we will still need more clinical trials to help us really seal the deal on how best to implement them. And I'll thank you for your attention.
Great, thanks, Stephen. Thanks for that look into the future, that glimpse. It's some very exciting work. So we're going to move on now to Gemma Figtree, because as Stephen has hinted, we're not just going to learn from these various emerging biomarkers about prediction, we're probably also going to learn about how things work in atherosclerosis and perhaps pave the way for developing new therapies. So over to you, Gemma.
Thanks very much, Gary, and thanks, Steve. And Don, that was a terrific overview. First of all, happy World Heart Day, everybody. I'm here just to follow up with, I guess, opportunities we now have in the next 5 to 10 years of really cracking new markers and also understanding new mechanisms by which coronary disease susceptibility is driven. I've got to learn how to do technical things. So a lot of people still, it's not until they actually turn up either in the cath lab or in fact don't even make it to the cath lab with sudden death as their first presentation of atherosclerosis. And we still rely at a primary care perspective on traditional risk factors as the major mechanism by which we categorize people in terms of giving them evidence-based treatment to prevent their disease. But we've known about many of these things since the 1960s. And whilst this has actually made massive difference to our ability to prevent disease at a community level, we still end up with patients on the cath lab table looking up at us saying, why me? At a primary care level, I imagine this is even more disempowering because many of your patients who you've done absolute optimal care for will still end up in this situation. So there's room to improve. And obviously, as Don has alluded to, you know, it's not about absolute individual risks, but it's about the combination. But it's also about the host. It's about the individual and their susceptibility to these factors that's driving it. I mean, I think this particular example that demonstrates the lack of overlap between the individuals that actually present with disease, women in particular, versus the Framingham and the kind of Q risk score in this particular case, is actually quite profound. So whilst risk factor scores are really good at a community level, and absolutely we need to try to do everything we can about the modifiable factors we know about, ultimately we're not completely winning. And interestingly, as illustrated here, what we see, in fact, we've coined the term SMURF for people, SMURFless for people who have no standard modifiable risk factors. There's an increasing proportion of individuals in our community that are actually suffering acute heart attacks in a life-threatening way without these standard risk factors. And this is just local data from the Northern Sydney Local Health District, where we see an increasing proportion of this. And this is obviously a multitude of factors contributing to it, most likely to do with competing risks, where actually in primary care, we're doing really well at treating the risk factors that are driving disease. But in this case, in patients presenting with ST elevation infarcts, we're seeing this increasing proportion of people with no risk factors at all. And here we've got Scott, who's actually a researcher at another institution, who went to the GP 3 or 4 weeks before presenting with a life-threatening heart attack. He had no risk factors at all, and ultimately, obviously, had been brewing atherosclerosis for this entire, 5 to 10 year period beforehand. And he presented with an acute infarct and a VF arrest as he was wheeled into the cath lab, having been riding 20 kilometres to and from his home and the institute beforehand, the days leading up to it. And ultimately, the question is, how do we actually get better at measuring, ideally, the disease itself, so the host response? And we've seen that coronary calcium scoring is one way of trying to do this. But the blood is passing through here, obviously many times a minute. Surely there must be something in the blood that actually potentially marks the individual host response. Many of the emerging markers that we actually see are things that actually relate more to the kind of myocardial response than the actual atherosclerosis. But I think what I'm about to present to you is, the new opportunities. With large cohorts and improved phenotyping, particularly of subclinical atherosclerosis, which is the exact thing that we're trying to find in a way that doesn't involve screening the entire population with a CT scan. New technology platforms for high throughput omics measures are one opportunity. And this actually provides an a priori opportunity for discovering markers in the blood that actually reflect disease activity or novel mechanisms actually driving disease. Furthermore, the massive improvement in big data and bioinformatics provides the ability to actually try to process this data in a way that we couldn't have dreamed of even a couple of years ago. And then there's obviously the innovative platforms that many of you, we would love to involve in terms of how we test the utility and value of emerging risks in this process. And I mean, imaging itself is actually providing an opportunity for research to better test and actually study new markers. When we relied on events for defining coronary artery disease, we might see this chap here with a single lesion in his LAD. And obviously he's had a life-threatening ST elevation infarct. But this chap here would actually be considered a completely healthy individual around, and he had no problem at all, with lots of atherosclerotic disease, but no event to date. So this is something that new tools can actually help us deal with at a research level. And patients having clinically indicated CTs provide an opportunity for this. We have a high sensitivity for anatomical disease, but also it's the best test for normal coronary arteries to better define the actual healthy cohort that we can use for biomarker discovery. Professor Nichols and I are actually involved in a study called BioHeart, which is actually just using in Australian populations, people referred for routinely indicated CT coronary angiograms, but we're taking blood at this point and then following up with ongoing outcome data. But advanced analysis of the CT plaque, as Professor Nichols has alluded to, provides us with lots of information far beyond what just the pure clinical information is. And when you're trying to actually identify new markers, this is very powerful, obviously in combination with outcome data. So we're trying to move beyond the situation where we've got, as in the top left-hand corner, patients with either low risk factor scores and high coronary disease burden, or high risk factor scores and, in fact, interestingly, low or high resilience to disease burden, and actually come up with markers that can actually identify those and provide us with information about novel mechanisms. And the resilient patients are actually really interesting here. CT coronary angiography, when performed for routinely indicated reasons, often provides people with amazing surprises where they actually sometimes have no disease despite a whole host of risk factors. And those people are actually potentially as a source of fantastically useful information about disease mechanism. So this is a study that's supported by New South Wales Health and obviously involves high technology and also lots of people involved in the team. People might imply that this is a bit of a fishing expedition, but ultimately the tools have never been better to go fishing. And there are a lot of fish out there, as we've seen, with individuals still turning up with no hint of a risk. Omics is a word that's used for basically a lot of the process, from anything from genomics, transcriptomics, proteomics, metabolomics, immunomics. It's all of the kind of a priori measures that we can do in each of these bits that moves from the host genome all the way through to the environmental impact on the individual. We've made some recent discoveries in the BioHeart study, which just confirm that many of the metabolites actually reflect atherosclerotic disease. And some of these will actually be drivers of disease and mechanisms of disease, and some of them will actually be reflecting of disease activity. And ultimately, actually understanding both of those things is going to be really important. If we could have a measure that was actually actionable, that was a reflective of disease activity in the blood, that would actually be a very helpful thing, particularly in the primary care setting. And this is obviously a long way still from clinical practice, but advances in phenotyping inflammation has got to move us far beyond the currently available high-sensitive CRP. Luckily, there's been some massive advances in this where we've able to use even just dry blood spots to actually measure over 200 different immune subpopulations. And this is something that can actually provide us information about various markers that are actually reflecting either soft plaque or calcified plaque. And in this case, we're looking at pro-inflammatory monocytes or CD39 positive CD4 cells that are associated respectively with calcified and soft plaque. And this is certainly a long way off where we are able to apply it clinically, but the rapid nature of all of this is actually fascinating. And genomics, as Professor Nichols alluded to, is actually a really important player here. But actually mixing the genome with actually these markers that are in the blood and closer to the actual environmental impact provides us with a true host response. So I think the next 10 years is really exciting. I think for those of you that are actually in primary care, one of the absolute missing links in a lot of this is actually a really a pathway that actually can take novel discovery through to clinical practice. And to do that, we've actually got to have better use of big data, virtual registries, but also embedded clinical trials in practice to be able to demonstrate that the biomarkers that we have can actually help patients. It's got to be easy to measure, it's got to provide new information, and it's got to be able to help the clinician to manage patients and improve outcomes. So we look forward to working with you all, and there are massive opportunities in the next 5 to 10 years of really just being able to be precisely targeting the best preventative therapies we have to the individuals that are at risk. So this is obviously looking at the horizon, but I think ultimately the application of this is going to depend on working very carefully between the clinicians and the translational factors that are coming through. So thank you very much for your time. I look forward to being part of a very active discussion on this front.
Gary, you're on mute.
You're on mute, Gary.
Well, thank you very much, Gemma. That's really exciting prospect for the future. And we've heard some very fancy stuff tonight, but a lot of the audience are going to have to face a patient tomorrow and make some kind of decision with what we have and what we can do. And I'm going to start, we've got dozens of fantastic questions. I don't know how we're going to get through them. I'm going to start by actually asking the audience, polling the audience a question. When you see that patient tomorrow and you want to explain to them what their risk is, what would be most helpful and do you think most useful in driving behavioural change and responses to therapy? If you could tell them what their risk was going to be in 5 years or in 10 years or in a lifetime, because there are different algorithms around the world which do all of those things. And then we'll go see what your view is of some of the things that you've heard today about what you think you might be using in the next 5 years. Will you be using imaging more? Will you be using novel biomarkers? We haven't talked about them much yet. Polygenic risk factors, or the one I can't see, I don't know whether you can, at the bottom is all of the above. We'll give you a few seconds to vote on those. You'll get an opportunity on your screen. I'm sure something will happen in a minute to give us a result from that. But in the meantime, I'm going to combine a whole lot of questions that we've had from the audience, because as I said, we haven't gone too much into the presently available biomarkers. So we've had questions about high sensitivity CRP, about homocysteine, about high sensitivity troponin, about lipoprotein A, omega-3 indexes. It goes on. Some of these are cheaper and easier than even the CT calcium scoring. Where do they stand with the panel at the moment? Do you think any of them are ready to be incorporated into our risk assessment?
I'll lead off and see what my colleagues think. You know, I think it's very biomarker dependent, and there are a number of factors you have to consider in understanding the utility of many of these novel biomarkers. All of the ones you've mentioned have shown independent associations with disease, but that's not really the question. The question is, do they improve the utility of our understanding who will have an event from who won't? So to take CRP as an example, CRP is associated with disease even after you've adjusted for the traditional risk factors, but it's a pretty modest association. So does it really truly reclassify someone by knowing their CRP level? And the answer is very few people. So if you want to put this on a scale, high sensitivity CRP will reclassify somewhere less than 10% of people more appropriately, moving the people who are going to have an event up, people who aren't going to have an event down. So 10% or less would be reclassified with CRP. The similar number for coronary calcium is in the range of 40 to 60%. So you're going to get a better answer from knowing whether they actually have the disease than from measuring another kind of non-specific risk marker. Now, the closer the biomarker gets to actual target organ damage, something like BNP in an older person or high sensitivity troponin in an older person, the better that biomarker is going to perform. And I think Gemma discussed that really nicely.
So Gary, the other thing to consider with regards to some of those biomarkers you suggested is some of them may be ultimately useful in secondary prevention in terms of triaging patients to more specific therapies. So Lp(a) is something that we test occasionally. Well, when we've got Lp(a) lowering drugs and we've shown that they're safe and they reduce events, well then knowing somebody's Lp(a) is probably going to be important to know. So, if we come back and have this same conversation 5 years from now, it may be a very different conversation, but in a different context.
Sure. We've got a number of questions about age, both younger people and older people. Most risk algorithms really deal in the range 45 to 75 or so. What do you think we should be doing in younger people that seem to be at high risk? Got a really strong family history or got, hypertension, hyperlipidemia, other things. And a little later, we might talk about older people too.
Gary, my thoughts are that a lot of this risk re-stratification is so focused on statins that it often forgets the ability of actually lifestyle change to make a big difference to some of our younger patients. Obviously statins may still be relevant in this group, but if you can actually talk to them about their risk in relationship to their peers, it is actually still really important. And, that can actually motivate them, particularly if we can actually develop a marker that actually reflects their disease activity or their atherosclerotic, their vascular health on a more positive front. That measure is something that we don't have. And if you're trying to treat hypertension, you can measure it. If you could try to actually treat vascular health and actually measure it, that would be the ultimate in the way of actually biomarkers.
I think the other thing to think about young age, Gary, is you've got to think about the context of the cohorts that we've derived these measures from. So as Don said, a lot of risk kind of algorithms came from Framingham. They were kind of middle-aged, kind of white individuals. Perhaps it's been a little bit better with the new generations, but I see a lot of people, for example, with FH in their early 20s, and I say to them that it's a whole different ballgame with regards to trying to interpret things. A calcium score of 0 for a 25-year-old with a normal LDL is different than somebody who's got FH, where there's potentially a family history of premature disease, and so you've got to be able to use a little bit of nuance in terms of the way that you kind of apply some of these things, particularly in younger individuals.
Well, I think that's really important, that that family history as a starting point, and understanding, whether they're extreme elevations of risk at young ages. Those are all sort of red flags for me to look a little deeper and maybe measure an Lp(a) in primary prevention setting here if there's a strong family history of premature cardiovascular disease. But you're right, Stephen, looking for coronary calcium, you're not going to get much of a yield until starting at age 35. Even in your FH patients. And so, I think really being careful about understanding what the family history is and whether they're extreme elevations, and then implementing lifestyle as early as possible. Completely agree.
Let's talk about some risk enhancers. You showed us that in certain population groups, Don, that the standard equations underestimate risk in culturally and linguistically diverse populations, people disadvantaged, people under psychosocial stress. What should we do? How do we handle that? What do we do if we know that the algorithm's underpredicting?
Yeah, I think unfortunately for many of those things, not all, but for many of them, we don't have a simple quantitative, readjustment factor to say, oh, well, if you have this risk enhancing factor, I just multiply your risk estimate by 1.5. That would be great, but it's not always that simple. So, I think if you have an estimate that's on the border of considering statin treatment in this case, and you've added on 1 or 2 risk enhancers, I think that should prompt a more intensive discussion about the benefits of statin for that individual. Whereas if there are none of those risk enhancing factors present, that might make me feel a little bit less pushed to do that if the patient was right on the border of the decision point. But this is where coronary calcium can be incredibly useful, because again, I think it answers the question we want to answer. Does this patient have advanced atherosclerosis that would change my decision about therapy?
Thank you. let's get really practical, and I'd be interested in your views on the widely available preliminary online CVD self-assessments. Do you think they have a place, and to what extent do you think they have reasonable validation?
Steve?
Well, I think the first thing to say is that, I think giving patients and Don really talked about it. I mean, it is a shared decision making between patient physician. So I think that whatever we can do to engage individuals and have them be part of understanding risk and about making decisions is a good thing. So I think the idea of developing accessible scores and calculators, I think that we need to find ways that we can encourage that, because I think that there's an overall net benefit kind of for the population in terms of engages people and think in terms about prevention. Because why are they looking at those scores otherwise?
Yeah.
Yeah, and Gary, it's important to say that, just to build on what Steve was saying, that there are available scores that don't require laboratory values. For example, there's one international-based score that substitutes BMI for the cholesterol values. So if you can measure your blood pressure, you can actually calculate your score, and it performs reasonably well with that substitution of BMI for cholesterol, as an example.
So you've helped answer a question I was going to ask about low resource settings. That's one way in which lack of resources can be addressed. One of the questions that's come up quite a bit in different ways is, why aren't certain things in the equation to determine risk? And particularly, for example, some of them don't have LDL, yet we know LDL is very important. Can you explain, because I think that's poorly understood, why some things drop out once the equation's derived?
I guess I'm the statistics egghead here, so I'll take that one. Yeah, when you look at the ways that variables get into a risk equation, it's a lot about the precision of the measurement, and it's a lot about the association with the outcome. With LDL, recall that for most studies, it's actually a calculated variable. So you're adding the error of the total cholesterol measurement and the HDL cholesterol measurement and the triglyceride measurement to get a very imprecise estimate of their LDL cholesterol. So it's much more precise to use the total cholesterol and the HDL. What you're representing then in the equations is actually the non-HDL cholesterol, which may be even a little bit better than LDL. Although I think we all agree that at present, LDL is the target of therapy. For risk assessment, actually having the total in HDL is a better way to understand risk.
Fine. Any other comments? No?
No, that was perfect. Thanks, Don.
Okay. Look, it's 2020, so I have to ask about I have to mention COVID. Do you think in future we'll be asking people, as part of their cardiovascular risk assessment, whether they've had COVID-19?
Yes, although I think Don will get a lot more affirmative answers than we will.
I was going to say the Victorians might.
Maybe I'll get a few more answers than most other people will.
Yeah, so
you hurt me.
Yeah, look, and actually, I think we need to think about the context of what it means for primary prevention, and importantly, and what worries many of us, what it means for secondary prevention and cardiac rehabilitation. We've been deeply concerned about those patients who have had an acute event, whether they've come to hospital, and when they have come to hospital, have we been able to get them effective, aggressive preventive therapies on board, which they then kind of maintain over the next 12 months. So I think we'll be asking that question in multiple forms.
Great. Look, I've got two more questions, and then I think we need to think about wrapping up. One is a really important one, and that's the differences, the gender differences which could emerge in risk assessment, and particularly things like pregnancy complications and other things in women that we know are important, and they don't appear in most of our risk calculators. How can we remedy that? I think you get this one, Jim.
Yeah, absolutely. Look, I think that, I mean, even with the things that we have strong evidence for, we're just not getting across the line with implementation. And as we look at the next 10 years and we see the technology coming out with all of these, new markers that are then strongly associated with disease in, big cohorts, it's actually testing it prospectively that's going to be so important. And I think ultimately that's not what we've done with any of these markers. And I think for women, we desperately need new markers. And some of the things that we've known for a long time with disease, we need to actually test prospectively about incorporating into algorithms. And I think this is something that certainly Steve has taught me a lot about. And he's a strong supporter of how we actually improve risk identification in women. But Steve, your thoughts?
Well, I think the other thing is the importance of actually just taking a history, which is what Don said in the first place. So, women have, preeclampsia happens. The overwhelming majority of preeclampsia kind of gets better with delivery of the baby. Blood pressure's okay, and everybody just gets on with their lives. Well, that actually puts you into a higher risk kind of category, and these are simple questions that we should be asking when we're seeing people for risk assessment. I think, Don, you touched a little bit on mental health type things as well, and so there's a range of other questions which shouldn't necessarily need to take a long time, but could actually help stratify risk enormously if we just simply asked the patient.
Yes, but the pathways for that to then influence the treatment that we're going to give the individuals still needs to actually be tested. I mean, ultimately, are you going to shift their risk category, and actually change their therapy is something that we absolutely should have pathways to test. And I think we desperately need these.
Yeah. Well, and now we're awakening to the fact that women get heart disease as well.
Yes.
We can perhaps do research in that space and work out how we're going to tackle that.
Okay, I think we'll continue this offline, but a really important point actually, and I haven't got time to ask you about wearables, and we don't know where they're going to fit in the future anyway. We do need to wrap up. We might just put the result of the poll up on the screen while I make some closing comments. It's clear that we've got some existing tools that are extremely useful and valuable in influencing therapy and influencing population health at present, but there's quite a promissory note in the talks you've heard tonight about things are going to get even better with more evidence, and we just may be able to move eventually from population average kind of risk to that in a particular individual. Interestingly, Australia stands out as having the five-year risk equation. The US, most countries use 10-year. That was mainly driven by consumer preferences. So it's interesting that our clinicians also think that something a bit more immediate might be something they can talk to patients about. And as you can see, most people think we're going to be using all of the above, although I think they're a bit optimistic about 5 years. We have the opportunity for the Australian audience of an MBS item to help you regularly assess absolute cardiovascular risk in primary care. We've got an even better opportunity coming up as the Heart Foundation is going to be leading the development of a new absolute risk guideline, and the sort of discussions tonight will certainly inform us on that. Visit the website for any more information. And register your interest for the upcoming launch of the Heart Health Check Toolkit for use in primary care. Thank you to all our attendees. Thank you so much to our panel. I think they've given us an extraordinary amount of information in a very short time. We'd be grateful for your feedback with a short evaluation survey. That'll automatically pop up when this webinar ends. And also, thank you so much to Natalie Raful and Jessica Zinn, who made it all happen.
Yes.
Good night, good morning, good evening.
Happy World Heart Day, everybody.
Happy World Heart Day.
Absolutely.